All right. I'm Dr. Andrew Kloberdanz, prior fellow of the University of Washington Boise program, practice family medicine and addiction medicine out in Parker, Colorado. And today I'm going to be talking with you about fentanyl versus opioids. So when we say detoxification, I kind of view detox and treatment as one and the same. It is pretty rare nowadays where it would be recommended to just kind of say, all right, we got you off the fentanyl, and then just kind of kick them to the curb. We're definitely going to make sure that we're treating someone through this. So we'll talk about a little bit of the kind of like finer details of it is all. And we can go to the next slide. I don't have any financial disclosures. Next slide. There we go. Learning objectives. So basically, looking to describe fentanyl, why it can be a little more difficult to treat sometimes, general trends in opioid deaths in this country, basic treatments for something like an opioid use disorder, and maybe describe the different methods for something like a buprenorphine induction. And next slide. So starting off, what is fentanyl? It is a synthetic opioid, meaning that it is not found in nature. It has to be made in a lab. What makes it kind of dangerous? It is an extremely potent molecule. On average, depending on what study you look at, they range it anywhere from 70 to 120 times more potent than morphine. So a little bit goes a very long way. And the molecule itself is extremely lipophilic. So when it is ingested, especially in larger quantities, like some of our patients who've been using it for a while, it finds its way into the fatty tissues of the body. And this becomes a problem later on when we're actually looking to try and treat someone for it. Next slide, please. So this is pretty cool because for the first time in a while, we are actually seeing that the number of kind of overdose deaths involving opioids has actually decreased a little bit. This data is from 2023, which was the latest chart I was able to find, unfortunately. But you can see the general trends from like the kind of late 90s there all the way up. It was just a pretty constant line up. And now it finally kind of crested a little bit and is going down slightly. So we might be starting to get a little bit of a handle on this, which is nice. Next line, please. Or slide, I should say. All right, so this chart here, which I'm sure everyone has seen at least like 20 times if you have been on this lecture series, because we like to show it a lot, kind of, basically shows that the reason we're talking about this whole fentanyl thing is fentanyl really kind of overtook most of the other opioids. As I mentioned, it's made in a lab. It's actually pretty cheap to make in a lab. You can make a lot of it and it's easy to ship, once again, it's so potent that it basically gets mixed into everything. And that's also one of the big problems is that it gets mixed into everything. So we have found things like fentanyl in, like methamphetamine. Like I think a more recent DEA kind of survey basically found that of all of the kind of like, pressed pills on the street, 42% of them contain at least 2 milligrams of fentanyl or more, which if you happen to be a more opioid naive individual and say you were going for something like an oxycodone, and all of a sudden you get hit with 2 milligrams of fentanyl, like that's an exceptionally dangerous situation for you. So it's a big deal, the amount of fentanyl just kind of floating around there. Um, I think that was the big stuff I had to say about that. So next slide, please. So I mentioned a little earlier that fentanyl is a highly lipophilic molecule. So gets into kind of the fatty tissues. And, basically the kind of big problems with this are twofold. Number one, brain happens to be very full of lipids. So when, you ingest something like fentanyl, it is pretty darn easy to cross that blood-brain barrier. And, basically these cells, yeah, for keeping the blood-brain barrier up are also made of lipids. So it just kind of like passes right on through. Um, and basically it's quickly diffuses into the brain. It's very quick acting, and that is partially what leads to its incredibly addictive potential. Basically, as you get a molecule, the quicker on, quicker off it gets, it kind of like really reinforces that dopamine hit, and very problematic for individuals who happen to be more susceptible to these kinds of, addictive molecules. The second problem is in patients who use significant amounts of fentanyl, it starts to diffuse into the rest of the fatty tissues in the body. So basically, the body is starting to kind of like store it up a little bit. And after you stop taking fentanyl, you're still going to have some of it circulating around as it starts to leach back out of those fatty tissues and make its way back into the bloodstream. Um, and therefore it can kind of get back into the brain as well. So you have more fentanyl floating around. There was a small study that was performed that basically took a look at urine drug screens for fentanyl in individuals who had habitually used versus not habitually used. And in individuals who had not habitually used, or who had habitually used, I'm sorry, and stopped taking fentanyl, they would still have a positive EDS, like 13.3 days on average afterwards. So that kind of tells you how long it is just leaching out, floating around the system, and ultimately causing some problems, is the idea. Um, and with that, I think we can move. Oh, hold on a second. Yeah, we can move on to the next slide. So, I just told you about some of the problems with something like fentanyl as far as it being extremely addictive and floating around in the body for longer because of this lipophilic nature. So now we get to talk about, what does something like treatment look like? And it's not going to look all that much more different than if you're treating just I guess I'll call it more run-of-the-mill opioid use disorder, something like, morphine or oxycodone or something. So you got your four main ways. You have the cold turkey method, where you kind of help the patient get through withdrawal and you don't give them any opioids to kind of help with any of the cravings or the withdrawal period, and they just decided they're done with it and they feel terrible for a while and then it stops eventually. Ultimately, not a super great way to go about this. The studies show that most patients don't tolerate cold turkey kind of discontinuation of opioids, and they tend to kind of head on back to those opioids pretty quick because withdrawal can be truly terrible. Another option is naltrexone. They have both the tablet version and the long-acting Vivitrol version, which is, I guess they call it kind of like a drug-free way of treating something like an opioid use disorder. You're not replacing it with another opioid, which some patients with opioid use disorders have a very strong opinion on taking another opioid to get off of an opioid. So this could potentially be an option for them where, you can give them an injection after they have gone through the kind of withdrawal period. And then the idea is that either the Vivitrol injection or the daily naltrexone tablet kind of blocks off those opioid receptors so that if they were to try and use something else, they would not necessarily get the high, and you're kind of rolling with what's called the extinction basically method, where they didn't get anything from taking a drug, so then they want it less and less, and ideally they would no longer want any kind of opioids in the future. Um, Overall, the kind of biggest problem that I think a lot of the addiction community has with this medication provides no mortality benefits. So, with other medications like Suboxone and Methadone, which show that when you're treating patients with these medications, their risk of death from kind of like a relapse and opioid goes down, we don't get that with Vivitrol or naltrexone. So, it can potentially help treat them, but they are still statistically at a higher risk of death compared to someone who is treated with Suboxone and Methadone. Moving on to Suboxone or buprenorphine, the generic name for it. It is a partial opioid agonist with an opioid antagonist mixed in with it to reduce the abuse potential, basically. So, if taken correctly, the patient will get the buprenorphine. They will not get any of the naltrexone or naloxone, sorry. And they're able to kind of treat the cravings, the withdrawal, and kind of keep their opioid use disorder nice and controlled without any real negative kind of downsides to it. Um, Let's see here. Honestly, it's one of the gold standard treatments for opioid use disorder next to methadone. You're able to take it at home, which is pretty nice. Some patients, transportation is a real issue. So something like a methadone clinic can be an ask to have them go to it every day until they can get more on take homes if they ever qualify for something like that. And what's also cool about the Suboxone and buprenorphine in general, it provides a little bit of a opioid overdose protection, um, because the buprenorphine molecule binds extremely tightly to the opioid receptors. So the theory being that if a patient was taking Suboxone regularly and then had a relapse to something like oxycodone, a little bit of fentanyl or something like that, that they wouldn't necessarily get a large high from it, and they'd be protected because those fentanyl or other opioid molecules would just be bouncing right off that receptor where the buprenorphine has been hanging out. And then the fourth option is methadone. Probably one of the, I think it is actually the oldest kind of treatment for something like an opioid use disorder. Works extremely well. With methadone, that is a full agonist. So, unlike the Suboxone, which only partially activates the receptors, methadone fully activates the receptors. Comes in a convenient kind of like daily dosing form. It's a liquid, so you can really dial in exactly the dose that the patient needs to control any symptoms of withdrawal or of kind of like cravings or anything like that. So it can be a very useful tool. Um, yeah, I think that's what I had for that slide. So we'll move on to the next one here. So the big thing with fentanyl, precipitated withdrawal. It was kind of the boogeyman in the room for a while, where there had been some kind of like case studies of patients who had been given whether it was Suboxone, well, mostly Suboxone actually, and then they went into precipitated withdrawal. Um, Basically, there were a couple of studies back in 2009 that kind of really dove into it and raised those concerns. And overall, it seems like those fears might have been a little overblown. There was a recent study, I think it was been 2022, where basically it's 1,200 ED presentations patients who had tested positive for fentanyl, and who received buprenorphine induction in the emergency department. They were experiencing withdrawal at the time, and they didn't really kind of say like, oh, you have to be at X number of kind of a cow score or anything like that, or severe withdrawal. They just kind of went ahead and gave them the buprenorphine. And with kind of those study parameters, they found that a precipitated withdrawal rate was less than 1%. So overall, is it still a thing that can happen? Absolutely. Does it happen all that often? Really doesn't. And, some of these patients had used fentanyl even just like less than 8 hours before, really. So they kind of got them started in the emergency department. They contacted them 24 hours after discharge and really didn't see any significant change in precipitated withdrawal or anything like that. So, it's something we need to think about, and it's worth asking when a patient last used fentanyl to help kind of gauge what kind of induction we're going to do. But it's not something we have to be overly concerned about. Next slide, please. So let's talk about some buprenorphine strategies here. So this is going to be for this particular slide is for patients who are not using fentanyl. So I'll just kind of call it the more run-of-the-mill like opioid use disorder, where for the longest time, there were kind of two main methods. You have the kind of traditional like office-based method, where basically you have a patient abstain from using any kind of their opioid of choice. They come in and we do a COWS score on them or a clinical opioid withdrawal scale. If they're in the kind of like high, mild to moderate range, you give them a dose of Suboxone, usually 2 milligrams. See how they do over the course of 30 minutes to 45 minutes. If they're still experiencing withdrawal, you give them another dose and you just kind of repeat that cycle until eventually they get to the point where they are not experiencing withdrawal anymore. That's their ultimate daily dose. You send them home with that, you have quick follow-up. The other option for patients who just really are not able to abstain from any kind of opioids long enough to enter significant withdrawal is you can do the low dose induction method, which basically the idea here is we are trying to replace all of the kind of like opioid molecules that are floating around, activating those receptors slowly over time with buprenorphine so that we can take a patient gradually to Sorry there, my mouth got ahead of my brain. Basically, the idea would be to slowly kind of like fill those receptors, but not so fast that we're going to cause a opioid withdrawal, and eventually they get to the point where so many of those receptors are saturated with buprenorphine from this kind of like very slow induction that even if they took something, they wouldn't necessarily feel a high from it. And as I said, really decent kind of like strategy for patients who just cannot abstain from opioids. Next slide, please. So I threw these in. Basically, these are a couple of the kind of clinical scales that you can use. So this here is the COW score, which is validated for in-office use. Has a bunch of kind of questions you go over, basically looking at things like vital signs, seeing if the patient's feeling particularly anxious. Are they having kind of piloerection, where like all the kind of hairs are standing up? Are they having diarrhea? Those kinds of things. Useful if you're doing, say, the kind of traditional method of Suboxone induction. And then on my next slide here, we have something, it's called the SALS score, where if a patient was maybe not interested in doing like a kind of low induction, but didn't necessarily want to stay in the office, you could send them home with this score right here. They can get into a moderate state of withdrawal, which they just answer everything subjectively just there on that page. And then they start taking the buprenorphine exactly as I had described in the previous slide. So can be useful. I've done it on a few patients, works pretty well. Next slide, please. All right. So this is buprenorphine strategies if you have a patient with fentanyl use. And you're going to notice it's not all that much different. You can still do things like the traditional induction. You can do the low dose induction, which for a while, and I think still is actually like fairly popular with those who are really concerned about a kind of like precipitated withdrawal. This once again just very slowly replaces those molecules, saturates those receptors to the point where a patient doesn't feel that they have to use fentanyl anymore. Or you can do what's called the high dose induction, which there were a lot of articles, and I know the last time I went to ASAM, everyone was kind of talking about it, where you get a patient, comes into the emergency department, which is where this is usually done. They're in withdrawal, and you basically slam them with buprenorphine, anywhere from 16 to 24 milligrams in a single dose. And if needed, you can even add beyond that. I have not really heard about any just kind of like outpatient clinical offices doing it. It seems a little bit bold to me, but it is certainly an option available if you feel comfortable about it. Let's see here. And then next slide, please. All right, methadone, oldie but goodie, still has an extremely important role to play in kind of this fentanyl area for both just regular kind of, I keep saying regular, but both fentanyl and non-fentanyl opioid use disorders. Um, as I said, can be a little difficult for some patients if they have transportation issues, just because they have to come into the clinic every single day until they can get on take homes. But it is extremely effective for them. They get their dose of methadone, they can start to feel better almost immediately. They can ramp you up really quickly. Like it's a very good treatment method, and I think still an extremely valid treatment method. The only downside is the kind of federal guidelines kind of put a cap on like the starting dose of methadone. And they have they're more guidelines rather than like stringent requirements for how fast you can take a patient up. But a lot of clinics are finding that you can kind of ramp patients up quicker than the old kind of like recommendations were. And that's been doing a really good job of helping patients in this kind of more fentanyl area where something like, say, if you had a patient who was using something like oxycodone and was doing fine on like 60 milligrams, you have patients come in who are doing literal like grams of fentanyl a day. Like that's not going to cut it. They're going to be up in the hundreds for something like methadone, but it can still be very effective to help treat them. So very reasonable option. And especially if they don't tolerate something like Suboxone or they want to go on methadone, absolutely get them referred over to a methadone clinic. And I think with that, next up is just all the sources that I kind of created for this lecture. Didn't create, used.
Awesome. Thank you so much. Great presentation there. And we've got lots of time for Q&A, which we always love. So would love to invite you guys to ask your questions and thoughts. Todd, do you want to go first?
Yeah, so Andrew, how would you use we've been over this before, but I think it's good review and for
Mhm.
people. How would you use the cows and the sow score um, when you're doing the induction with fentanyl, and how is that different than, non-fentanyl opioids? What
Got
numbers are you talking about with those? Yeah.
um, I think depending on the kind of studies you find, they'll give you a little bit of a different recommendation when it comes to like the sows and the cows score for a fentanyl versus non-fentanyl individual. For something like the cow score, I have often seen anywhere from like a 10 to 12 is considered that kind of like mild to just getting towards the moderate for withdrawal, which is very reasonable to start a patient who has not taken fentanyl on buprenorphine with a very limited risk of something like a precipitated withdrawal. When we're talking like for fentanyl, I've seen a recommendation for the cow score to be up around like the 15 to 17 range. I'm honestly not sure how often that was or how well that was validated because once again, they also found that like something like precipitated withdrawal is not a particularly common thing that we actually experience in the real world. But it's something to keep in mind. Um, the SAL score, which is the home-based, basically you just kind of shift those numbers up because I think moderate withdrawal is usually around the kind of 15 to 17 range, and that's kind of what they recommend for the normal, like non-fentanyl. Then it can be a little bit higher for um, kind of fentanyl users. But once again, not we can use them as guidelines, but you can also kind of go by feel and how the patient's kind of doing at the moment. Does that kind of make sense?
Yeah, yeah, thanks.
Cool.
I have kind of an anecdotal question for
Mhm.
you. You mentioned about the study about fentanyl and the urine toxicology testing.
Mhm.
So I had an interesting question from a primary care clinician. They had a patient who had a like an endoscopy procedure or something like that. I can't remember exactly, but something outpatient procedure where they received fentanyl for sedation.
Okay.
And then a drug test did show fentanyl about 10 to 14 days later. Um,
Hmm.
but BMI around, mid 30s. And this is just an opinion question because I don't think there's any data for this specifically. But, you know, and this is also, considering avoiding drug testing around, the perioperative period.
Mhm.
Do you think there's a chance that that came from the sedation fentanyl as a one-time dose, or do you think it's
Yes.
pretty unlikely?
My kind of gut, and once again, as you said, there's not like a ton of data on this, is that I think it would be pretty unlikely. Most of the time when I have seen these kind of like endoscopy procedures with the conscious sedation, I mean, we're giving you fentanyl in the order of like over the course of the entire procedure, 100 to 200 mics,
Right. Yeah, less
which
than 250 almost every time. Yeah.
yeah, so for that to truly still be kind of circulating around the system and make it into the fat stores and then not come out that quickly, I'd be suspicious.
Okay. Yeah. I mean, I think that's kind of what we thought. They ended up not seeing us anyway, but so never got to
Fair.
follow up on the end of the story. Um,
Yeah, that's an interesting one.
yeah, I mean, because then it leads me to think like, okay, should because we do drug testing for
Mhm.
chronic opioids, and now we're considering like, okay, is there a recent procedure? I think our feeling is we're not going to change any methods regarding the procedure, just try to interpret it.
Sure, sure. Yeah. And I mean, I'm sure like if it was like the day before, we wouldn't be having this
Right.
conversation because you'd be like,
Right.
yeah, that makes sense. But yeah, 14 days is that's a long ways.
We had a question in the chat from Katie Pond, and
Mhm.
maybe Nina, this might be a good question for you too. When people have worked up to the ability to have take-home methadone, what period of time are they able to get covered before they need to return to clinic?
Yeah, sure. I'm not sure I quite understand the question exactly. Can you say it again, Shannon?
I
How
think
long
they're
are they
asking
covered?
like
Take,
um how much methadone can they get at a time before they have to return to clinic for their next? doses?
That is a good question. And as Andrew had mentioned, there have been some recent changes to the federal guidelines on the take-home schedule for methadone. It's actually gotten a lot more flexible, which is really nice. So our clinic in particular, we are not open 7 days a week. And so when a patient starts with us, they generally are required to come in daily. They do get to take home their weekend take home doses from their admission. So we don't require the federal guidelines as well as Race Bottom doesn't require any treatment days prior to being able to get your weekend take home doses. And then I'm just going to pull up the schedule here so I can give you the exact schedule. So when patients have been in clinic for up to 1 month, they are allowed to get up to 14 take-home doses. And after a month, they're allowed to get up to 28 take-home doses. Now, that schedule is quite flexible, and we don't typically do that. So we typically require patients to be in treatment for at least a month before they get an additional day. And they do have to have their urine drug screens do have to be as expected, so no illicit substances, and then they can start getting take-home doses. So after about a month or so, they can get an additional dose, and then so we're sort of in right now we're in this transition period, right, where we used to be a lot more strict. It used to be, I mean, you would have to be in clinic for, come into clinic daily for up to 3 months before you really started getting additional take-homes. But in the past year and a half or so, with the federal guidelines actually becoming a lot more lax, we're sort of feeling out how comfortable we are with allowing patients to have, that many take homes. So it is a process, and it takes about a week for everybody to review. So you have to put in sort of, an application, if you will, to increase your phase, is what we call it, to allow you to have more take homes. And it has to be reviewed by your counselor. You have to have a meeting with your counselor. It has to be reviewed by the providers. We have to review, whether how you're doing in treatment, what your urine drug screens are showing, and then make a decision as to whether it's approved. And so people will typically get one additional take home, and then after a couple of months, they'll go to an additional, I guess it's like 3 additional takeouts. So they'll have a week take home. But they do have to still do some things like they have to come in for random drug screens. They have to, so we do random callbacks where, if you have your medication for a week, you have to be willing to do what's called these callbacks where, the clinic will call you and say, you're getting a random check. You need to come in and show us how many bottles are empty and how many are still full. And so that happens pretty frequently. And people do have to, if you miss a callback and you're not able to come in and show how many bottles you have empty or how many are full, then you'll go back to daily dosing. If you relapse and, your urine drug screens show some sort of illicit use, you go back to daily dosing. If you're unstable for any reason, if you feel like your dose isn't stable, you'll go back to daily dosing. But so there's a schedule. And it patients slowly ramp up from starting out with weekend take-home doses to one additional, then 3 additional for the week, and then usually after about 6 months or so, they'll get another week. After about a year, they'll be able to get a whole month of take-homes, basically 28 days, so 4 weeks of take-homes. But they have to work up and they have to be showing, commitment to treatment, having, strong foundation of recovery, no relapses, working on counseling, therapy, things like that. So, but it's fluid. It is fluid because of all these changes right now with the federal guidelines changing, getting a lot more surprisingly flexible.
Nina, thank you so